Thank you for giving us the opportunity to present our case here. Myself, Raj Jayaraj, I'm consultant respiratory pediatrician, and
I'm Claire Lord. I'm physio for paediatrics, respiratory and cystic fibrosis.
So we are based at Middlesbrough in UK, which is the northeast of England, and we are smaller centers compared to the Germany that show, and we have about 58 patients in our cohort. Can you see the slides moving?
Yes, absolutely. Thank you.
So moving on to our first case. Before that, I'm just going to ask Claire to give us some background.
So just because in the UK, and especially within our centre, we haven't been using Simeox very long. So within our centre, we've probably only been using it about a year and a half. And obviously we've had COVID in between, which has put a spanner in the works. So today, both case presentations we've used with IV therapy, but it's the first time that both patients had used the Simeox device as well. And so for people logging in from the UK, we might chat a little bit about how we got them started on it as well, just to give a little bit of advice there as well.
So we have used this in both inpatient setting as well as at home. So it gives you some idea about how it could be used in both settings. So I'll move on to the case. The first one is a 17-year-old boy who is a Delta F508 homozygous, and he was born with meconium ileus, and he was diagnosed with CF at that time. And subsequently, he colonized with multiple microbiomes, and the specific ones he's colonized as chronic Pseudomonas and persistent Staph aureus. And then he went on to become colonized with the NTM abscessus type. He also developed diabetes along the line, and he was really struggling to gain weight. Most of the time, his weight swings between 38 to 40, maximum of 42 or 43. And that's including overnight peg feed. So on background, he has got a Portacat, so he gets regular IV antibiotics on 3 monthly basis just to keep him on in a good condition. He attends a local college, and he was doing a mechanical course, but unfortunately, because of frequent admissions and exacerbation, his course was getting quite a lot of discontinuation process, and he was quite unhappy about that. And he is from a very low socioeconomic group according to the UK standard. And when he comes to stay in the hospital, family don't visit him often, so that kind of shows some involvement of the family is not that good in his CF care. And he just have one good friend at college who is very supportive, and he likes talking about, and he's quite a chatty, energetic boy otherwise. As you can see, he is on cocktails of medication. The one to point out, he was started on Orkambi even before the UK actually approved this medication on wide usage. So we got to him through the compassionate grounds. And during this exacerbation, the IV treatment, he wasn't on Kaftrio, but currently he is on the Kaftrio. He's also on other medication, and he's one where we put him on alternate treatments of Bramitop and Colabrid. So he goes 1 month on, 1 month off on the other ones. And for airway clearance.
So he uses his Aerobica with hypertonic saline daily, more often twice a day if he needs to. And he uses breathing exercises with his huffing and coughing. Often, even though he is 16, his mum would still percuss his chest because he felt that that was really good for him and it helped him clear. We did try to get him as physically active as he could, but he got out of breath quite easily, and so he didn't actually do too much physical activity. He also has a BiPAP machine, and he's supposed to be on the NIV overnight to help open him up, but he does not use this, not compliant at all. And so we use it as a physio treatment. So we'd put him on a BiPAP for 20 minutes prior to any physio or airway clearance that we were wanting to do.
Unfortunately, because of his microbe growing different bugs and his very low weight on his BMI, although he was referred for a lung transplant assessment, he got refused and he was not fit for lung transplant. That was a few years ago. So he was managed mainly as an inpatient. When he gets an exacerbation, he comes into hospital and stays with us for 2 weeks, at times up to 3 weeks. So his admission starts getting closer. We used to admit him every 3 months, but as the disease progressed, he was not lasting for 3 months, and he's having more frequent exacerbations. And he comes in, as I say, and starts on IV therapy and intense physiotherapy, and also his feeds. We readjust his feed so that he puts some weight on. His lung function, as you can see, just at the time, he was only blowing about FEV1 of 1.2 liters, about 30% for his age. And his smaller airways, FE25 to 75, was about 10%.
Physio-wise, we were using all of his normal techniques. He had really, really thick, green, sticky phlegm, really hard to expectorate, and he'd often make himself vomit to try and to expectorate easily, or because of the effort of trying to expectorate. He hated physio, he hated being in hospital, and he often used delay tactics to try and distract the physios from doing anything. And he suppressed his cough because he knew once he started coughing, he almost couldn't stop, and it ended up in vomiting. I think as physios, quite often we go for positive pressure devices, especially in the UK, and we would use intermittent positive pressure on this young boy on admissions with IVs. However, he was quite hyperinflated, so we figured this would not be the best option. And he'd started getting little pneumothoraces, so we kind of wanted to avoid any positive pressure where possible. And so we thought we would give the Simeox a little try. So he's used to everything, so he was kind of like, what's the worst that can happen? Let's give this a bash. We took the time to explain the device to him. We went through all the different settings, all the lights, and talked about how it would work, because it's obviously very different to what he's used to in his normal physio. We got him in a nice, comfortable, relaxed sitting, and so that he could see the machine lighting up, so he knew when he could stop breathing out. Initially, we set it up to 10 breath cycles with 50% power. He absolutely hated it at first, and to be honest, I nearly dismissed it. But we tried again. We got it, hit the mouthpiece in a good position, and we tried again. We found that he tolerated lower power at 25% to about 50%. And we lowered the breath cycles as well to 6 breath cycles. So with the Simeox, there is different hertz for the breaths. So the last 2 are always at 6 hertz, and the first ones are always at 12 hertz. And we found with this patient that his lungs, or he, tolerated the 6 hertz better, and that kind of helped him expectorate. So we did more cycles but less breaths. We managed to complete this twice daily as an inpatient, and then made a decision that he could take this home and finish his IVs at home and keep the Simeox device at home a little bit longer. That was like the icing on the cake for him. He said that the Simeox felt much less effort, and it didn't make him as tired as other therapies. This is just a little chart to show his lung function from admission to when we discharged him, and then I went and did them at 3, 4 and 6 weeks of using the Simeox device. And although obviously he was on IV, so we do expect everything to increase anyway, and his FEV1 has increased as we would expect. But it's really interesting to see that his smaller airways, his FEF 25-75, has increased massively, and more than it normally increases with his normal physio of the Arabica and cushion. So that was really interesting. I think it is difficult to give hard evidence of how the Simeox works, but for us, the patient was reporting that he felt more comfortable. he was reporting that it was quicker and easier for him to expectorate, and he wasn't getting as tired. From my opinion as a physio, it seemed like a more controlled physio for this young boy. He wasn't getting as upset, he wasn't vomiting, and the phlegm seemed to come up a little bit easier. I wouldn't say that he was expectorating any more phlegm. It was just seemed more controlled on how he was getting it up. It also gave us more patient-centered care because he could do this care closer to home, and he engaged a lot better with us when he was using the Simeox device. And if we've got time, can we do presentation 2 as well?
Yeah. Can we carry on with the presentation, Lauren?
Yes, please.
Okay, thank you. Yeah, so moving on to the second case, she's a 16-year-old girl. In contrast, she also comes from low socioeconomic background, but she's also very stubborn, challenging teenager who refuses all the treatments for CF, and she sometimes point blank lied to us saying she's doing everything when we found out that she wasn't doing. So it's very typical teenage behavior, and she's an homozygous Delta F508 with pancreatic insufficiency, and she's colonized with Pseudomonas. She also has CF-related diabetes, which is very poorly controlled, and her HbA1c was very concerning at some point. She attends school, and she was introduced to our centers following her being moved away from London from her mum for child protection issues, and she was staying with her grandma and auntie locally. And she doesn't get on very well with the family members, and she tends to argue and fight quite a bit. That has an impact on her CF care. Again, she is on cocktails of medications, and her lung function was usually around 1.6 to 1.7 liters. We didn't put the percentage because we were doing home spirometry monitoring at that stage, so we were not able to get the percentage on that equipment. And in terms of airway clearance?
So airway clearance wise, she is supposed to use her Arabica with hypertonic saline and her a cappella when needed as well, but also she can do active cycle, huffing and coughing, and be physically active. So she enjoyed running and going to the gym. However, I don't think she did any of this. I think the most she probably did was a walk or a dawdle to school with her friends. However, she told us how compliant she was with everything.
So when we saw her in the clinic outpatients, her lung function suddenly starts going down again, and it's gone down to FeV1 of 1.4. And we also found out that she was hiding a medication and not taking those medications that she's supposed to take. And she suppresses her cough quite well, but we noticed she was getting more productive and wet. So therefore, we decided that we're going to treat her with IV antibiotics. But she refused to come into hospital. So we thought it's a compromise is to start the IVs at home and more daily input from our MDT team.
So we decided that we would support the IVs at home with Simeox rather than getting her to do her usual physio that we probably knew she wouldn't do if she was left to her own devices. We started her with the Simeox. Initially, I went out every day to complete it with her, to ensure that she had a good technique and to ensure compliance. This was the first time that I've taught Simeox at home in a home setting during a global pandemic. So it was really hard getting her on board while I was in full PPE and hard to explain it. But we worked a lot on her breathing pattern and AD breathing. Again, we started on 10 cycles at a 50% power, and then we decreased to the 6 cycles again to use the lower frequency breaths more often. After about 3 days, we increased to 10 cycle breaths at 75% power, which she found a lot easier and a lot more comfortable. So it was more the technique and more the breathing technique getting with her. I think that because she was so out of touch with doing a normal physio and a normal breathing technique, it was getting back into that pattern. So we actually did it in a bedroom where she could relax a bit more. And we used a poster, hence the poster of Billie Eilish, as getting her to do some rectangle or some square breathing. So she was inhaling on the shorter sides and exhaling on the longer sides. That made her focus on something else as well, rather than just watching the machine and waiting to expectorate. So this is her lung function from the start to end of her IVs. She was on IVs for 2 weeks, and in the middle, again, her FEV1 has come up as you would expect because she's on IVs, and her FEV1 had dropped quite significantly anyway. So I would say it's come up to a normal level. But again, you can see that her FEF, her smaller airways, has come up dramatically and probably the most. So it's gone up by nearly 50 mils. And then I've compared this. So I've gone back on her results from the last time she did IVs in the hospital. So the top table shows IVs at home with Simeox, and the bottom table shows IVs in the hospital with other airway clearance techniques. The other airway clearance techniques that were used in this child were intermittent positive pressure breathing and a cappella twice daily with a physio present. And although her start point was higher on the previous IVs because she was more unwell this time, you can see that her smaller airways, her F25, 75 has come up much more significantly than using other airway clearance techniques, which shows that we're getting down to that expiratory reserve and we're opening up the airways a little bit better with the Simeox. So on reflection to case study B, the patient actually reported that it was more effective than her usual airway clearance, which was amazing for her. She felt that it was easier and she felt really, really happy because it meant she could do more advanced physio in her own home and didn't need that hospital stay. In my opinion, it seemed again much more controlled. She never expectorates and suppresses her cough and will never ever give us a sputum sample. However, she expectorated with the Simeox. She swallowed, but she got some phlegm up, which was really, really good. And it increased her lung function. Again, we got patient-centered care and the patient actually complied with the treatment rather than just telling us she was complying. So in conclusion, I think that we've had a really positive experience using the Simeox with IVs. Lung function, that from these two case studies does suggest that it does increase our FEF 25-75. And I think the ease of expectoration in these patients that have got thick, tenacious secretions was also shown, and the patients aren't becoming overwhelmed with it. And I think from like a more safety aspect, I felt a bit safer using this device over positive pressure devices just for the risk of barotrauma and hyperinflation.
So the most positive side is this can be used both in inpatient settings as well as an outpatient or at home setting, which is really good. And it's not just the larger airway, it also has got some element of improvement on the FE 25-75, which is on the smaller airways. Again, I think as others alluded, LCI would be another interesting way of looking at these data and see how much it's improving before and after. I'm sure that somebody can do that and show us some data. We don't have LCI in the trust, so we were not able to do that particular test. Thank you very much. Thanks for listening, and hopefully there will be questions at the end that we could answer.
Thank you.